Morning and welcome to this session on optimization of GI imaging. Today promises to be a fantastic day for GI lectures and generally, but I'm going to open this session this morning very glad to be kind of introducing three fantastic speakers. We're going to be using questions and answers we're doing questions and answers towards the end of the session. The live discussion box is the place where you can post your Q&A, so please place them there, and all of the speakers will be available at the end. Without further ado, I'd like to introduce Dr. Oliver Duxbury. He's a consultant at Basingstoke. He's going to be talking today about CTC, or CT coronography optimization. Over to you, Ollie.
Thank you very much for having me. My name's Ollie Duxbury. I'm a consultant radiologist at Hampshire Hospital NHS Trust and part of the Peritoneal Malignancy Institute. It's an absolute pleasure to be here today to be part of this session, and today I'll be focusing on CT coronography. Time is limited with only 15 minutes, but I will give you an overview of why we need to optimize the study, what you can do prior to the procedure, what to do during the procedure, and what you can do after the procedure. So CT coronography, or CTC, is a highly sensitive test. It's extremely well tolerated by patients, and it's already used in the bowel cancer screening program, which shows how good a test it is. The number of studies being performed is high. We're already doing over 120,000 studies per year in England, and this is increasing, not only due to increased pressures, increased number of referrals to endoscopy services, but also the impact of COVID has resulted in more and more CTCs being performed. And just to mention, recently there are new standards of practice that have just been published with regards to CTC for services with regards to image technique, image quality and image interpretation, and I will touch on these later on. So why do we need high quality imaging? What exactly are we looking for? Well, obviously we're looking for cancer, and these two examples show clear examples of circumferential wall thickening, which are in keeping with a large tumour. But you could imagine, probably not to this extent, but if there was an area of poor distension, you could get circumferential fold thickening, which could easily mimic a tumour and create a pseudo lesion. So it's important that we optimise the scan so that not only can we identify cancer, but also reduce the chances of having a pseudo lesion. So not only are we looking for cancer, the great thing about CTC is that we can also identify early or potentially precancerous lesions, and these come in the form of polyps. But the problem is these early or precancerous lesions are often very subtle. They're often flat, sessile, and often on the right side of the colon. So three different cases with three very subtle areas of pathology. First case, there's a minimally elevated lesion just on the anterior surface of the bowel wall, which would be very hard to see if you didn't have good distension. This case here in the middle, there's some irregularity and on the posterior side of the wall, and again, if there was poor distension, this would be easily missed or mimicked by areas of poor distension. And also, I think this highlights the fact that you need good fecal tagging and bowel cleansing, because untagged feces would also mimic this. And the third case, again, a very subtle, minimally elevated lesion on the medial wall of the bowel here, and you can just make out a tiny bit of tagging from the gastrographin here, which is adherent to the mucosa, and that can be a sign that there's a lesion there. So without good bowel prep or good distension, these areas would be easily missed and overlooked. So what can you do prior to the procedure? Having clear patient selection criteria is really important, and every department will be different. You need to have a referral criteria based on what age you're happy to perform CTC on and which symptoms you're happy for patients to be referred with. Who can refer the patients? Really important. I think the people who are referring for CTC need to have a clear understanding of what the study entails, what the patients have to go through. It's quite common for junior doctors to inappropriately request CTC when they don't really understand what the test involves. So having clear guidelines of who can actually request CCT is really important. Do you offer a same-day CTC service for failed endoscopy? If so, again, you need clear documentation of what prep and how you perform these. And in regards to the patient, are they compliant? Are they going to be able to cope with the instructions for bowel preparation and bowel cleansing? Are they continent, not only for regards to bowel prep, but also on the day? Will they be able to keep the gas in? And how mobile are they? Again, this relates to bowel preparation. Will they be able to go back and forth to the toilet on multiple occasions? And also when they're actually being scanned, will they be able to be moved into the appropriate positions? And ideally, you shouldn't be performing CTC on patients with inflammatory bowel disease, any polyposis syndromes, Lynch syndrome, and also inpatients. From my experience, inpatient CTC generally results in suboptimal, poor quality studies. So wherever possible, you should be asking that these get referred as outpatients rather than inpatients. Having good patient information is really, really important, and communicating it clearly to them is vital. You need to provide patients with a patient information leaflet, and this has to be clearly worded with no jargon or technical terms and make it easy for them to understand. And this should clearly explain to them what to expect with regards to the diet, the bowel preparation, what it will do to them, and what to expect on the day of the study. And having a contact number for them to call with regards to any questions is really helpful. And this should be directed to an experienced radiographer who understands CTC well, and they will be able to deal with any questions or queries, and that will make the chance of the patient being compliant with the bowel prep much higher, and therefore you're going to have a better quality study. There's no consensus with regards to bowel preparation, but it's vital. Fecal tagging is essential. We use gastrographin, but as I say, there's no consensus. Other places use Picalax and Omnipaque, but either way, you need to have clear documentation and guidance for the patients. A low residue diet is really important, and you need to have specific advice for diabetic patients, and each department will have different advice, but it needs to be clearly worded and easily available for the patients. And again, just to reiterate, please have a contact number for patients to call. You're much more likely to have a compliant patient if they can call up and ask any questions prior to the study. So on the day, you need to confirm with the patients with regards to the bowel prep. Did they take it all? Does it sound like it's worked? And then this is your opportunity, if you're performing the study, to tailor the examination to the patient. Read the clinical history, read the question. Why have they requested CTC? Have they had a failed endoscopy? Is there a known tumour? In which case, which part of the bowel has already been assessed by endoscopy? Because your job then is to distend and optimise the bowel for the rest of the colon which hasn't been assessed. And by having confidence in the study that you're performing will put the patient at ease. So spasmolytics, Buscopan is essential unless it's contraindicated. It reduces spasm and peristalsis, so please do use it if at all possible. Below are the absolute contraindications to using Buscopan, and this should be clearly highlighted within the department so it's easy to know when and when not to use it. And please do document if it has or hasn't been used. Insufflation with carbon dioxide, very important, it's a key part of the test. Generally use automated carbon dioxide for a rectal catheter. And the key thing is to monitor the rectal pressure rather than the volume of gas that's going in. That will help guide you as to how the insufflation is going and give you an indication of whether you're getting good distension. And if you are finding that you're having problems insufflating, performing a scout image can help highlight an area of potential obstruction, whether there's a mass there or a stricture or even a hernia. And this example here just shows on the scout there's this circumferential thickening and a tight narrowing of the bowel here due to a tumour, and that would be impeding the flow of the gas. Patient positioning is really important, and you need to have 2 positions as a minimum. And the aim of positioning is to help optimally distend the entire colon and also redistribute any residual tagged material. Again, just to consider, you are tailoring the study to the patient. So is it a completion CTC? Has the left colon already been assessed? Therefore, your job is to focus on the right-sided distension. Which position to use? Well, again, there's no consensus and it is patient dependent. And also, as I said earlier, you are tailoring the study to the patient. So once you've done your first position, you need to review it to decide what is distended well and what isn't. And that will tailor then your choice of second position. And it's important then you review that second position. Do you need a third view or even a fourth view? And the recent guidelines that have been published state that you should be performing a third view in at least 5% of your cases. And if you aren't, you should be reviewing your practice. And a little tip here, check the scalp prior to performing the actual scan. If there isn't good distension, don't scan them. Just have a think, reconsider your options. Have you done everything you can do to optimize distension? Do they need some more gas? Have they had their Buscopan? Is the position good? And again, a little tip here, if you are using prone position, try and use at least 2 pillows under the chest to redistribute the weight. This is an example of using a third position. The left-hand image is the first position that was used, the supine. And the white arrow shows the right colon to have reasonable distension, but the folds are a little bit thick, and that's a sign of the distension not being optimal. And the yellow arrow shows that the left colon is completely collapsed. So a second position was used, this time right side up, decubitus position. And if you look at the folds highlighted by the white arrow, they're much thinner. And that is really good distension. That's a great sign of good distension. And I'd really advise you to have a look at the fold thickness when you're scanning, and that will give you an indication of whether you're achieving good distension. But the yellow arrow again shows the left colon to be collapsed. So quite rightly, a third position was used, this time to try and distend up the left colon. So a left side up decubitus position was used, and the yellow arrow now shows the left colon to be distended and the right colon, the right colon with the white arrow to be collapsed. With regards to the balloon, ultimately you just need to use as minimal air as possible to ensure continence. Younger patients don't need much air in the balloon, more elderly patients might need a bit more. But if you are inflating the balloon, you do ensure to deflate it on the second position, as there is a theoretical risk of obscuring low rectal lesions. The on-table review is a really important skill to practice. It helps you decide which second position to use. And also when you review that, do you need a third position? Do you need more gas? Or is there pathology? Is there a potential cancer? Should you be performing a chest CT to stage the patient? And the standards below highlight the fact that we should be staging patients at least 50% of the time if there is a cancer present. And the key thing here is practicing following the colon wherever possible. The more and more you practice following the bowel, you'll get better at identifying areas of good or bad distension, but also identifying pathology. So what can you do after a procedure? Well, a key thing I think is practicing doing the first read. Go through the study, try and identify pathology and get feedback from your reporting radiographers or radiologists. It's really important to have a good support network from your colleagues, as this will help develop your interpretation skills for the on-table review, and this will in turn help develop the quality of the imaging obtained and also when to stage patients. You need to clearly document various areas such as patient position, was Buscopan used, was intravenous contrast used, and what was the dose. And that all comes down to my final point in regards to audit of practice. Very recently, the British Society of Gastrointestinal and Abdominal Radiology and the Royal College of Radiology have joint produced some standards with regards to CTC. And they explain how to run a service and have key areas that should be audited regularly. And it's really important that this is being performed in your department. If this hasn't been performed in your department or you don't think it is, please go back and suggest it to your leads, because this is the only way really to develop and improve a service. As my final point, I just want to highlight the fact that no matter where you are in your career, you should always be learning and developing yourself. I just want to give a quick plug to something which is in the pilot phase, but there is a national CTC training and accreditation program which is being developed. And the aim is to standardize practice nationally with both regards to image acquisition and interpretation. As I say, it's currently in the pilot phase, so it's early days, and there's module A, which is based on image technique and acquisition, and there's potentially a second module on image interpretation. But if you are not involved in this already or want to get some more information, please do contact Rachel. There are her contact details. She's the research fellow at St. Mark's Hospital, and we're more than happy to provide you with any further information. So in summary, it's really important to provide clear information to your patients prior to the study, get as good bowel preparation as possible, optimally distend the bowel using below factors, and audit your service. Thank you very much for your time.
Thank you, Ollie. That was excellent. I'd like to now introduce Dr. Uday Patel, who's a consultant at St. Mark's Hospital, who's going to be talking about MR rectum and optimization of those kind of examinations. Thanks, Uday. Over to you.
Hello everyone, my name's Uday Patel and I'm a radiology consultant at Norfolk Park Hospital in London. I'm speaking about the optimization of MRI for rectal cancer, and I have no conflicts of interest. So why do we optimize rectal cancer imaging? Well, it's important to optimize to ensure staging accuracy. In this non-high resolution image, we see an anterior rectal tumor. The white arrow indicates likely extension through the bowel wall in keeping with T3 disease. When the imaging was repeated using a high-resolution protocol, the anterior tumor does not extend through the bowel wall. What I've done is highlight the tumor in yellow and the bowel wall in orange. So this change in stage from T3 to T2 would have potential treatment implications. For example, the colorectal MDT may offer a T3 tumor chemoradiation, but a T2 tumor surgery. So just to reinforce this point, this slide shows the variety of different treatment approaches that are considered depending on MRI tumor staging. So as Ollie was speaking about, what to optimize can be divided as what to do before the scan, what to do during the scan, and what to do after. I would emphasize before the scan communicating with the patient to ensure as much patient cooperation as possible. For example, telling the patient how long the scan will take and the importance of keeping still. It's also important to keep in mind that the patient may not know they potentially have a rectal cancer. The other thing to look at before scanning is optimizing the coil position. So here the patient is supine with the head pointing towards the magnet, and the coil is placed over the pelvis 2 inches above the iliac crest, 3 inches below the pubic symphysis. So the iliac crests have been marked on the images, and the level of the pubic symphysis is the solid black line. So in the top left picture, the coil position is too low and a corresponding blurry sagittal image has been obtained, while in the bottom right image, the coil has been positioned correctly and a good quality sagittal image has been obtained. So let's imagine we've started scanning, we've acquired the localizer and the wide field of view axial. The next sequence acquired is the sagittal. So this sagittal image has no saturation band and appears blurry. The quality of the sagittal image can be improved by using anterior and superior saturation bands, which will reduce the artifact from the anterior abdominal wall. So repeating the image with the saturation band has improved image quality here. After acquiring the sagittal images, most centers will give an antispasmodic agent. We give 20 milligrams of buscopan. We give it at this point as buscopan is relatively short acting, and we want its maximal effect during the high resolution sequences. The images show the beneficial effect of buscopan on reducing artifact from peristalsis. The top 3 images are pre-buscopan and the bottom 3 images are with buscopan. So moving on now to scan planes, we now begin planning high-resolution axial oblique images on the sagittal images. The oblique axial images should be obtained perpendicular to the long axis of the rectum. In this example, the plane has not been planned correctly, and the axial images, shown here, show apparent posterior rectal wall thickening. When the images are planned in the correct plane, perpendicular to the long axis, we see there is no posterior rectal wall thickening. So just another example of scan planes. Here's an example where the axial images have been planned correctly, with the planning box in the left-hand image perpendicular to the long axis of the rectum, and the right-hand image showing the axial oblique images obtained. High-resolution coverage should be at least 5 centimeters above the top of the tumor, as seen by the upper border of the planning box marked in yellow here. It should also be to the L5-S1 level for all tumors to ensure that discontinuous tumor deposits within the mesorectum are visualized. So looking now at the coronal images, these are planned parallel to the long axis of the rectum on the sagittal images. The coronal images are especially useful in low rectal tumors, where the lower extent of the tumor is at or below the puborectalis muscle. If a low rectal tumor has invaded through the bowel wall into the intersphincteric plane, seen on the simplified line drawing, or extends through the intersphincteric space into the external sphincter, then if a total mesorectal excision is carried out, this will likely result in a positive margin. Such cases are considered by the colorectal MDT for chemoradiation or wider extralevator excisions. So here are the parameters that we use at Northwick Park and St Mark's for a 1.5T Siemens scanner. Other scanners are obviously available. There are several parameters that we can potentially alter, and I'll talk about the 4 I've highlighted there. So we'll start with matrix size. So the field of view is the size of the area being imaged, in this example 180. The matrix size is the number of pixels in the field of view. So here 192 by 192. The pixel size is field of view divided by matrix. We can see that this combination of field of view and matrix size in this example has given a blurry image, as the pixel size is relatively large. So here's a simplification. Each individual square is a pixel making up the image. To improve the image quality, we can increase the matrix size and leave the field of view unchanged. This results in a higher spatial resolution as the pixel size is reduced. So here's a simplification. However, using this approach, the signal-to-noise ratio is decreased as there is less signal per pixel, and the number of phase encoding steps has increased, so the scan time has increased. So here's a summary text box of what happens if you increase the matrix size but leave all other parameters unchanged. Now here's a second example of matrix size where we have a relatively large field of view on the left-hand image at 320 by 320. Using this matrix, we have a relatively grainy image. So even though the spatial resolution is high due to the small pixel size, this benefit is outweighed by the loss of signal per pixel, giving rise to a relatively low SNR. So overall, too small a matrix leads to a blurry image, as the pixels are too large with low spatial resolution, and too large a matrix leads to a grainy image, as there is too little signal from each pixel, giving rise to a low SNR. So we find that a matrix size of 256 by 256 with a field of view of around 185 is a good compromise between these factors. So a little bit more on field of view. Here is an example of a relatively large field of view at 230 with quite a blurry image. If we decrease the field of view to 170, the image becomes much clearer. This is because with a smaller field of view, a smaller area is imaged, but the matrix size remains the same. So overall, the pixel size has become smaller and the spatial resolution higher. So here's a simplification of what we've done. The same number of pixels are in both of these simplified diagrams. So smaller pixel size increase the spatial resolution, but also decrease the SNR. So here's a summary text box on that. So just to mention an artifact to do with field of view, aliasing is also known as wraparound, and it's an artifact that occurs when the field of view is smaller than the body part being imaged. The part of the body that lies beyond the field of view is projected onto the other side of the image, as seen by the white arrows in the left image. To briefly explain aliasing, the continuous MRI signal is picked up by the receiver coil and converted into its digital counterpart for presentation as the image. This involves sampling the continuous signal at defined intervals. If the sampling rate should be at least twice the highest frequency within the signal. At lower sampling rates, higher frequency signals become indistinguishable from lower frequency signals, i.e. they become aliases. Aliasing in MRI can be compensated by enlarging the field of view, using saturation bands on areas outside the field of view, phase over sampling, as we see in this example, and switching the frequency and phase encoding directions. So another parameter to consider is the number of signal averages. So a way to increase the signal is to scan the same area several times and then to average the signal to create the image. So overall, more signal is collected per slice imaged. SNR is increased by the square root of the number of signal averages. This leaves the spatial resolution unchanged, but doubling the NSA doubles the scan time. So at Northwick Park, we use an NSA of 4. I know other departments such as the Royal Marsden use an NSA of 6, and I will include the Marsden protocol at the end of my slides. So here's a summary text box on NSA. So unchanged spatial resolution, increased in signal, but doubling of the scan time with doubling of the NSA. So how do we reduce scan time but maintain image quality? Well, if we reduce the NSA, we reduce the scan time, but that also reduces our signal-to-noise ratio. We could increase the field of view to increase the SNR to counteract this. However, increasing the field of view would decrease the spatial resolution. So to avoid too large a loss in spatial resolution, I wouldn't recommend increasing the field of view to more than 200. Another approach is to reduce the matrix size. This decreases the scan time, but reduces the resolution. Reducing the field of view at the same time counteracts this by increasing the spatial resolution. Our overall aim should be a pixel size of around 0.6 millimeters. Parallel imaging is where the placement and sensitivities of the receiver coils are used to assist spatial localization of the MRI signal. Having this additional information about the coils allows reduction in the number of phase encoding steps during image acquisition and a consequent reduction in imaging time. So scan strategies. If on the sagittal image you do not see a tumor, then one approach is to do axial oblique images throughout the rectum. An alternative approach is to do 3D space sequence. In the post-chemoradiation setting, there's quite a good body of research now showing that diffusion-weighted imaging is useful in distinguishing residual tumor from post-treatment fibrosis. There's a smaller body of work talking about using contrast in this setting. And I've already spoken about the importance of reducing scan time in claustrophobic and uncooperative patients. So in conclusion, we've covered what to think about before the scan, communication with the patient, ensuring patient cooperation. Keep in mind the patient may not know they have cancer. We've spoke about the pelvic coil positioning, and then during the scan, when to give the buscopan, where to place the saturation bands, the importance of scan planes or planning scan planes correctly on sagittal images. So the axial images are perpendicular to the long axis of the rectum, and you continue those slices above the level of the tumor to around 5 centimeters above the level of the tumor. Coronal images parallel to the long axis of the rectum are especially useful in low rectal cancer. And I've also given an overview of the trade-offs involved between changing field of view, matrix size, and NSA, and how they impact on scan time, spatial resolution, and NSA. As Ollie mentioned, after the scan, it's also important to conduct patient satisfaction surveys and feedback from the MDT on images acquired. So I'd like to acknowledge Rejosh George and Finbar Kalnan, who are the MRI radiographers at Northwick Park Hospital. Rejosh runs a website called mrimaster.com, which talks in great depth about technique, not just in rectal cancer protocols, but all of body imaging. Radiology Cafe has a very good section on MRI physics, and Radiopedia has an article on trade-offs. And here is the Royal Marsden protocol that I mentioned earlier. Thank you very much.
Thanks, Uday. That was brilliant. I'd now like to introduce Dr. Joy Barber, a wonderful colleague of mine at St George's Hospital, who's going to be talking about optimization of MR enterography. Over to you, Joy.
Thank you for the introduction, Jay. As he said, I'm talking about optimization of MR enterography. So we've got a little bit less time. We've only got 15 minutes, so it's going to be a very rapid canter through. Firstly, some indications and alternatives to MR enterography, and then we'll focus the bulk of the talk on different contrast agents that are available, enteroclysis, so distending the jejunum as best we can, and then we'll talk about a few other factors that you can adjust to improve the quality of your scans. So just a disclaimer, I am a paediatric as well as a GI radiologist, so I probably spend more time than average tweaking protocols and being tolerant of patients' individual preferences. So the bulk of what we do for MR enterography is inflammatory bowel disease. So whether this is identification of disease at the start of the process, whether it's monitoring response to the monoclonal antibodies or providing a roadmap for surgery. But there are a host of other indications that you can use it for, and it's a really good problem-solving tool in tricky patients. It's worth saying that MR enterography is not the correct study for everyone. So historically, we used to do barium studies, and occasionally they are still useful. So you can see up in the top left an example of a terminal ileal stricture in a patient with Crohn's disease. The problem with the barium follow-through studies is it's relatively high radiation dose. They're difficult to perform, quite difficult for the patient to tolerate, and actually you don't get that same 3D impression of what's going on in the bowel. You can get beautiful distension of the jejunum with enteroclysis. This is a barium study on the top right, which is a classic example of that slinky type appearance you can get in scleroderma. But again, we tend to use MR if we're going to be doing this rather than barium these days. CT is a very valid alternative, particularly in older patients. And that may be CT enterography with contrast, or in the acute setting, actually maybe just a standard contrast enhanced CT study, depending on the patient. In the paediatric population, we do a huge amount of small bowel ultrasound, actually, and the resolution that you can get for the different bowel wall layers is actually, I think, much higher on some of the new scanners than you can get with MRI. You don't necessarily need an oral contrast agent to prepare the patient for their small bowel ultrasound, and you can compensate real time for any patient motion. And of course, there's virtual capsule endoscopy as well. So the key is really picking the right study for the patient, and just being aware that sometimes MR enterography is not necessarily the be-all and the end-all of small bowel imaging. So as we've just got a couple of examples here, so for instance, in this 2-year-old who just had newly diagnosed inflammatory bowel disease, actually ultrasound was the best test for them. We got the highest resolution, and when we did attempt an MR enterography, didn't go particularly well. Whereas this 70-year-old coming through A&E appropriately, even though their inflammatory bowel disease patient had a CT study. So why do we worry about optimizing our MR enterography? Well, the features that we use for diagnosis of disease on MRI rely on having good distension of the small bowel. So if you have a study such as this one, where the patient has not really drunk that much contrast, you can't really assess the wall thickness, the T2 signal, and you're going to get a lot of artifacts on your DWI and your contrast enhanced sequences. So these are the things that you can tweak that we're going to talk about, and we're going to start with the enteric contrast agents. There are a wide variety of options available, and there's quite a lot of literature comparing one between the other. The best guidelines really for overall how to perform an MR enterography is still the ECHO ESGAR guidelines. They're a few years old, but they're still a good read if you haven't come across them yet. And actually there's, as they say in the guidelines, there's no strong evidence that favours one particular oral preparation over another at the moment. Any of them are available, whatever your patient population will tolerate. The key to them is that they need to maintain good distension of the small bowel throughout the small bowel for the duration of the study. In general, the patient will need to fast for solids for 4 to 6 hours before the study, avoid carbonated drinks, but they can keep taking their regular oral medications. They start drinking the oral contrast agent 45 to 60 minutes before the examination, depending on how much small bowel the patient has got. And there is evidence that really you need about a litre or so of the oral contrast agent to get good distension. It's important to warn the patients beforehand that they might get some cramping and diarrhoea afterwards, and to provide appropriate facilities for the patient to manage that. So just going back to the options available. As we said, the oral contrast agent needs to stay within the bowel lumen for the duration of the study, so water probably isn't going to be sufficient for that. Depending on where you are in the world, so in the United States, they particularly like Volumen, although increasingly are moving towards Breezer, which is a highly flavoured sorbitol drink, which is slightly more palatable than Volumen. Most places in the UK use mannitol at 2.5%, which gets good results. But actually, we have increasingly started using in our younger patients and in patients who find the mannitol difficult to tolerate, a low volume lactulose preparation. And what we do for this, it's a much smaller volume of the oral contrast agent. So it's just 50 mils of lactulose, topped up to 100 mils, so a 1 cup of contrast agent really, mixed up with a nice flavoured lemon squash. And then they can just drink water or squash or whatever they want for the next hour or so. We find they tolerate this pretty well. And our personal experience is that it gives good distension, so equivalent to our lactulose and better than the methyl cellulose agents we used to use. So the key, really, for getting good distension of the bowel is to make sure you find something that is palatable for the patient and get good patient buy-in so they understand how important it is to drink that oral contrast agent so we can get diagnostically acceptable images. There are a couple of other things that you can do. If you refrigerate your drink before you give it to the patient, that can improve the palatability. As I've said, you can add some blackcurrant or lemon flavouring, and also mode of delivery. So something as simple as giving it to the patient in a water bottle rather than in an open cup can actually make it quite much easier to drink. In terms of jejunal distension, it's an area that is often the least well distended part of the small bowel on the study. If you want to go the whole hog and get really excellent distension of the jejunum, you're going to be looking at having to put down an NJ tube and slow drip in the contrast as an enteroclysis study, which is extremely time consuming for the patient and for the scanner. and incurs a radiation dose as well, because you're going to need fluoroscopic guidance to get that tube down. Actually, what I found is that just giving the patient an extra couple of cups of water just before they go into the scanner room often is enough, just to give you sufficient jejunal distension. Okay, so that's the bulk of the talk about the enteric contrast agents. We're going to move on to a few other modifiable factors. So there is some data to support that you do get better distension of the bowel when the patient is lying prone versus supine. The other big advantage of lying the patient prone is that it compresses them in the AP diameter, so it makes the patient thinner, essentially, so you can get through your coronal sequences faster. And also, if you start moving on to motility imaging, it reduces the likelihood that the bowel is going to peristalse in and out of plane whilst you're acquiring your sequences. However, there is no evidence at the moment that this actually affects the diagnostic accuracy of the study, and it's perfectly acceptable to put the patient supine as well. And a lot of patients will be more comfortable supine and therefore will stay still. Similarly, with Buscopan, actually the bulk of the studies do show that the distension is better with Buscopan, but it's not suitable for all patients. Some patients may have contraindications. Some patients may find their dry eyes and dry mouth intolerable. If you are going to give it, you can give it either as a single or a split dose, but the key is that you have to give it before the motion sensitive sequences because it is short acting. So just moving on to gadolinium, which has become increasingly controversial over the past few years. Gadolinium is extremely helpful for MR enterography studies, particularly good for penetrating disease, so identifying fistulas, collections and abscesses. But the reason that we worry about it increasingly are the deposition diseases. So both nephrogenic systemic fibrosis, which has been around for a few years with the skin complications, but also increasing evidence that it deposits within neurons. And of course, these are young patients who are coming back repeatedly throughout the year for multiple studies for probably the rest of their lives. So if anyone is going to get problems from gadolinium deposition, it's probably this cohort of patients. So the reason that you might want to give gadolinium, as well as for looking at penetrating complications, is actually there is some evidence to support it being useful in assessing activity of disease. It's part of a lot of the validated scoring systems for that reason, and it can help looking at the pattern of enhancement, looking at inflammation, fibrosis and tethering. There is, however, increasing evidence that we can use other things to supplement for that. So, for instance, the T2 signal within the bowel wall, DWI and motility can also help to give us an idea of activity within the bowel. And I'm just going to spend a little bit of time moving on to those supplementary sequences, just to go back for a second. So the DWI motility are actually increasingly used in clinical practice. Magnetization transfer and the T2 star imaging is still very much in a research setting, so we don't really have time to cover that today. So if you're going to do DWI imaging, recommended values are p-values of 0, 15, 600, acquired axially with the patient free breathing, and a maximum slice thickness of no more than 5 millimeters. And there's good evidence that it improves sensitivity for identifying disease. And initially there was a lot of excitement with lots of different thresholds proposed for different ADC values, active from, severe active, from mild active, from inactive disease. But actually, as time has gone on, we found that the thresholds proposed for measuring ADC values have problems in terms of the repeatability of measurements. So although DWI is very good for increasing sensitivity of detection of disease, there are problems with the specificity. If the bowel is not well distended, you can get a lot of artifact, and it can also show up false positives, for example, lymphoid hyperplasia. So useful, but we're probably not there in terms of using it quantitatively for assessment of disease activity. Okay, let's see if this works. Excellent. So motility imaging, just an example of some of the beautiful pictures you can get for small bowel motility. This is a stack of rapid T2 acquisitions which are acquired over a short period. So we do 15 seconds, at least 1 frame per second, very high temporal temporal resolution. Sorry. The reason we do this is there is evidence that actually motility changes with bowel activity, and that if the bowel is actively inflamed, it has reduced motility. If you are going to be doing motility imaging, there is evidence that actually you are better off using software to quantify the results. And there are commercial packages increasingly available, as well as through research studies. Is a motility image, such as we have on the bottom left here, which is color-coded, with low motility, dark blue, and higher areas of motility in red and green. So you can see on the right-hand image, where there is active disease, there is more blue within that highlighted red area compared to the normal bowel on the left-hand side, which has a higher motility score. Okay, so in summary, we've been through the indications for MR enterography and the alternative of selecting the right study for the patient. We've talked about different contrast agents available, how to improve your jejunal distension, and then how to optimize your scanning position. So whether you do prone or supine, if you should be giving buscopan or gadolinium, and some supplementary sequences which are available. And really the key is doing the right scan for the right patient. And these are patients who come back repeatedly for multiple studies every year. And I would suggest that it is actually worth finding out which study that they're best for, whether the patient tolerates MRI better or ultrasound better, if the patient has a particular preference for a particular contrast agent, and whether they are happy to tolerate buscopan. And if you can tailor your study to your patient, then that's how you're going to really optimize your imaging. Thank you very much.
Thank you, Joy. That was excellent. We're going to move to questions now. I can't see any questions on the live chat, but if there are any of the attendees that wish to ask any questions, please do so. I'd like to welcome my 3 other colleagues up onto the virtual stage now. And whilst we're waiting for any questions, I have a couple for each of you, if that's okay. Ollie, you talked about bowel prep being an incredibly important part of the kind of optimization of imaging for patients with CT colonography. One of the questions that I get a lot from our radiographers who kindly do a lot of vetting is what to do in patients with who have been requested for a CTC who have a low GFR. Do you have any particular practice or what do you do with these types of patients?
Similarly get asked this question quite a lot, and I think the key thing is you've got to tailor it to the patient. So you've got to look at all the other factors as well, not just the eGFR. Have they got other comorbidities? Are they diabetic? Have they got cardiac impairment? But generally, if their renal function is okay or borderline, it's fine. It depends what agent you're using, but most places use gastrografin these days. But key things to do, more importantly, to check with the patient is, have they got support at home? And as I was saying in my talk, to have a phone number which they can call if they're struggling or have any questions, so that you can help guide them through the process, ensuring they're staying hydrated and tolerating things okay. So I think the important thing is to obviously recognize when they do have renal impairment, but generally it's okay, provided they've got the support network at home and also at your end in the hospital to help them through it.
Yeah, no, I fully agree, Ollie. I think certainly that's my practice as well. I think keeping hydrated is really key, and I think it leads to a better quality CTC as well. I think there's less mucosal tagging or kind of gastrografin coating when patients are better hydrated. Thanks, Ollie.
Yeah.
Uday, I was going to ask about planning, and actually, I think this can be quite difficult. It can be quite hard for us, let alone our radiographer colleagues, to identify the tumour when they're planning, and so hence it becomes difficult to plan a true axial and coronal oblique through the tumour. Are there any particular strategies that you can suggest that might be helpful for them?
Yeah, so thanks for the question. I mean, I covered it briefly in the talk, so if I just expand on it, I think if you're in a situation where you don't see the tumor on your sagittal image, so you're unsure of the level, then you've got two options. You can either do plan high resolution axial oblique images throughout the long axis of the rectum, or you can do what's called the 3D fast spin echo sequence. I called it the space sequence in my talk. That's the different manufacturers have different proprietary names for them: space, vista, cube. But essentially that sequence involves taking high resolution continuous images in thin section throughout the rectum. And because that sequence is isotropic, so the pixel sizes are the same in 3 dimensions in the X, Y, and Z planes, then those axial slices can be reconstructed in essentially any plane you want, or reformatted in any plane you want. So the radiologist reporting can then change the plane of the scan to optimize seeing anything they think looks like a tumor. I mean, that sequence, just moving off your question slightly, is also particularly useful if the patient has a very advanced cancer. So you have a cancer that has expanded or has invaded beyond the rectum into other neighboring organs. So if you're unsure, for example, about the degree of involvement of the prostate, then reformatting in a different plane may well help you, and may also help communication with surgeons if they're planning more extensive excisions. So I think those are your two options in summary. It's the 3D fast spin echo sequence, or doing high resolution sequences, axial oblique high resolution sequences throughout the rectum.
Thanks, Uday. And maybe going back a step, but why is it so important to get a true axial oblique through the malignancy? What's the ramifications if we don't, or if it's slightly obliqued in reality?
So I think, as I showed on the slide, if the plane is not perpendicular to the long axis, then you can get a sort of pseudo-tumor effect where you have, in the example I showed, a posterior rectal wall thickening. So a reporting radiologist may well look at that and think that is part of the tumor, or that is the tumor. So that's one point. So the second point is that if the plane has not been planned in a perpendicular way, then establishing extension beyond the bowel wall, so T3 disease, becomes more challenging, because now you're dealing with a plane that doesn't cut through the bowel wall at a right angle. And then once you don't know if the tumor's gone through the wall, then it becomes very difficult to establish whether the resection margin is potentially involved. So it sort of has a knock-on effect throughout the report, that you're unsure about the T stage, you'll be unsure about whether the margins are involved. So it will become quite a difficult scan to report, I imagine.
Yeah, I fully agree. Thanks, Uday. And I'm just checking this. I don't think there's any other questions in the live chat as far as I can see. So just my last one for Joy, if you don't mind, Joy. You talked about the various different types of imaging acquisitions. You know, we've got post-contrast, we've got diffusion weighted, we've got cine sequences. Do you think that we should be performing all of those sequences in all of our patients? Or do you think there is room to be slightly more strategic with how we image our patients with MR angiography?
Absolutely. I think a lot of optimization of MR enterography is about tailoring the study to the particular patient and to the particular question. And so, for instance, I won't give gadolinium to all of our patients coming through, either because I feel like they've had enough, previous doses on their previous studies, or because I don't think it's going to particularly answer the question for the study. So if I don't have a high level of suspicion that they've got penetrating disease, I'm more likely to skip the gadolinium, for instance. Or if I have a patient who looks like they probably haven't got brilliant distension of the small bowel on their initial localizer images, I'm more likely to ask if we can add in a motility sequence, which I find actually compensates to some extent for poor bowel distension, because you can see the peristalsis, and you might catch the bowel in the moment when it distends nicely. So yeah, absolutely. I think it's all about tailoring the study to the patient, and that is, adapting which particular sequences you run, as well as what oral contrast agents, etc., that you're giving them.
And it is that.
And of course.
Sorry, go on.
Well, I was going to say, and also that you've always got the option, if you do an MR enterography study and you think, oh, I just missed the terminal ileum, you can always supplement it with another study. It's very, you can do an additional supplementary small bowel ultrasound, for instance, for a targeted bit of bowel, or vice versa. If you've done a small bowel ultrasound and you just haven't quite seen down in the pelvis, then you can go and do the MR enterography. It's all complementary.
I agree, and just on that note, it is often why it's so nice to have all of those imaging modalities under your arsenal, or in your arsenal rather. You can go to other safe imaging modalities to get the answer that you need for clinicians. Joy, I just wanted to ask about the practicalities of tailoring your MR study, and is that something you do when you're vetting? Or is that something that you do, or is that something that you get the radiographers to do when the patient's on the table? How does that work for you?
For instance, so most of the time it's done at the vetting stage. So the patient comes through. So I will generally have a look at their previous imaging, see if they are a patient who gets good bowel distension on their MR enterography, or if they're a patient who has never been successful at drinking their oral contrast, in which case I might switch them to a different study. But when I'm vetting, I always say, this patient should have a choice between, mannitol or lactulose. And then when they come on the day, actually most of the patients are regular attenders, and they've tried both and they know which they prefer. So giving them a choice, I find, actually makes them more likely to drink it. So it's a combination of the vetting stage and on the day.
Perfect. I think that's all from me. I can't see any questions on the live chat. I hope the session's been useful to all the attendees listening. I think it's been a fantastic hour-long session, and my colleagues, Ollie, Uday, Joy, thank you so much for the time and effort you've gone into preparing those presentations. I thought they were brilliant. Please do visit our partner portal, our partners on the links on the side, and also the sponsors. We look forward to seeing you at the next couple of GI and hepatology lectures later on today. Thank you all. Bye.
Thank you.